So I want to thank Dr. Vernino and the MSA Coalition for inviting me to speak at this year's annual conference. It's my pleasure to participate in the conference again. And today I will be speaking to you on the topic of sleep in MSA. So my name is Mitchell Miglis. I am a neurologist at Stanford University in the Division of Autonomic Disorders and Sleep Medicine. These are my disclosures. None are relevant to this discussion. I am on the advisory board of the MSA Coalition. However, this is an unfunded position. So, overview of sleep disorders in MSA. As many of you probably know already, almost every patient with MSA has some form of sleep disorder. Sleep disorders are incredibly common in these neurodegenerative disorders, in all neurodegenerative disorders, but especially in those of alpha-synuclein deposition, of which MSA is one. And compared to Parkinson's disease, a more commonly recognized and a more common disorder of alpha-synuclein, MSA patients have, in general, more sleep disorders than patients with Parkinson's, at least 77% of patients in some studies versus 51% of patients do have a sleep disorder. And sleep disorder can be any form of sleep problem. In fact, most patients have several sleep disorders, and they can be any diagnosable sleep disorder, including insomnia, sleep disorder breathing, such as sleep apnea, RBD, which stands for REM behavior disorder, restless leg syndrome, or RLS, and problems with circadian rhythms. And we'll get into the specifics of each one of these. And so again, these are the conditions that we are discussing in general that cause many sleep disorders, the alpha-synucleinopathies. MSA is one form of an alpha-synucleinopathy. And it is characterized by deposition of this protein alpha-synuclein. In MSA, it primarily involves the central nervous system, the brain, and parts of the brainstem. And this is important because the sleep disorders that typically result from MSA are the result of this protein depositing in certain areas of the brainstem and the brain, which cause disruption of certain neurological pathways that influence sleep. And so the first disorder we'll discuss, which is incredibly common in MSA, is called REM sleep behavior disorder, or it's abbreviated RBD. And so RBD is characterized by acting out your dreams. So when we dream, we can have vivid imagery, but evolutionarily, the brain has designed a system where we should not be moving during dreaming. And in fact, the muscles in most of our body are paralyzed, so we don't act out the dreams, so we don't punch or kick or jump out of bed. But because of where that synuclein protein is deposited in parts of the brain stem, it disrupts that pathway. So the muscles are disinhibited, or patients are suddenly able to move during their dreams. And there can be quite violent movements. Here is an example of a patient here having an episode. There can be punching, kicking, flailing. Often these are direct enactments of the dream that the patient is having. And so you can see there's semi-purposeful behavior, sort of reaching and kicking, but it's not like sleepwalking. Patients don't get up, walk around, open cabinets. They don't usually leave the bed. And patients can jump out of bed if they're having a violent dream, but they don't get farther than the floor, right? So if someone is sleepwalking, that's different from something like this, where they're in the bed and typically doing violent activities. If you ask somebody, what were you dreaming about, they can often tell you. And the patient's eyes are typically closed and they don't talk back. And this is different from sleepwalking, where eyes can be open or semi-open and patients can respond to questions. Interestingly, it's much more common in men than women. We don't know why this is. Could be that men have more violent dreams. Could be that women who are caregivers are more likely to report this than vice versa with men. Another important characteristic is that because this is happening during dreaming, during dream sleep, the events are much more likely to happen in the second half of the night. So middle of the night, early morning, because that's when we have more REM sleep. And I'll show you an example slide that explains that in the next slide. And it's important to realize that generally, RBD is very common, affects about 1% of the population. In MSA, it's about 100% of patients with MSA. So almost every patient with MSA has RBD. And I want to bring your attention to the bottom graph on this slide. This just shows different sleep stages throughout the night. And the bars in red at the top here, these are the REM or dream episodes. And we can see as the night progresses, these episodes become progressively longer, and there's more of them in the second half of the night or the early morning. That's why most of us remember our dreams more in the early morning after we wake up out of a dream. So if somebody's having sleep-related movements at night, we always ask, is it happening more in the first half or the second half of the night / early morning? If it's second half early morning, more likely to be a REM phenomenon. So again, very common, about 100% of patients with MSA have RBD. This tends to occur later in the disease, as opposed to Parkinson's disease, where it may be one of the earliest manifestations of the disease, occurring decades before someone might develop movement abnormalities. In MSA, we think that it manifests as the disease is, at least in the moderate stages of progression. Again, there's a broad range of motor manifestations, but usually they're violent. Sometimes it can just be limited to talking, yelling, or vocalizations. Again, walking is rare. That's sleepwalking. That's a different disorder. And it's always important to recognize this condition because there's a very high rate of injury. 60% of patients have reported an injury to themselves, and 20% or more to the bed partner. So the first thing we always want to go through with patients that have RBD is your bedroom safe? So you want to make sure that your bed is not very high from the floor, that you don't have a hardwood floor directly, under your bed that you could fall onto. Patients have fractured bones, broken hips. You don't want to have any sharp bedstand that you can jump into. Facial fractures or lacerations are fairly common. You definitely don't want to have a window next to your bed. You don't want to have any weapons, basically any sharp objects next to your bed. And if the events are frequent and violent, it is best if the bed partner sleeps in a different bed. If you do decide to continue sleeping in the same bed, you do want to have some kind of barrier between the patient and the bed partner, such as a soft, large body pillow to prevent injury. And this is a very good question, to ask. We ask patients this, or to ask yourselves: Have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements, etc. And diagnosing RBD is very difficult without discussing this with the other person in the bed, because self-awareness is quite limited with this condition. Many times when we're dreaming, we fall back asleep. We don't remember the dream or what we were doing. So you really need the history of the spouse, the partner that has actually witnessed these episodes. So how do we treat RBD? Well, first we discussed safety. That's the priority. Melatonin is the first line treatment. Very little side effects. It's actually fairly effective. I would say around and up to 50% we're able to control the RBD just with melatonin alone. Usually start at a dose of 3 milligrams and go to a max of 12 milligrams 30 minutes before bedtime. Melatonin in the US is not FDA regulated. It's a supplement, so we don't know the exact concentration in the supplements. There are various brands that might be better than others. Sundown is one brand that we recommend. Nature's Own is a decent brand as well. And usually I would start with 3 milligrams and then go up by 3 milligrams at a time if patients continue to act out to a max of 12 milligrams. At that point, if someone is still having episodes, depending on how violent they are, if they're just talking and really not any major risk of injury, then that's okay. But if there is risk of injury, then we'll think of adding in clonazepam at a very low dose, 0.25 milligrams. And often we'll add that to the melatonin dose. Clonazepam, I have to be careful because it is a sedative. It's a benzodiazepine, and it can have cognitive side effects. It can cause increased risk of falls. So we just have to be really careful using it. However, it is fairly effective for this, and we do use it in a fair number of patients if necessary. So the next disorder that's also extremely common is insomnia. I mean, insomnia is just generally common in the U.S. population and in the world population, global population. And we define this as difficulty falling asleep, difficulty staying asleep, or waking up earlier than you want to, with daytime consequences. So that's usually fatigue or trouble concentrating. And it has to be occurring frequently, at least 3 times a week for several months. And there are different models to sort of understand insomnia, because insomnia is usually not a simple condition to unpack. There's usually many factors involved. It's a multifactorial disorder. So there's a model, and this model has been employed in different facets of neuropsychology, called the 3P model. So there's predisposing factors, there are precipitating factors, and there are perpetuating factors. So example of a predisposing factor might be genetics. And we know insomnia is more common in women than in men, tends to run in families, tends to be more common in patients who are more worriers or have some history of anxiety. And then maybe there's a precipitating factor, a diagnosis of MSA, for instance, that really increases anxiety. That's a natural response. And then maybe there's maladaptive behaviors with sleep. Someone's not able to sleep as well. And then because of that, they start doing things that perpetuate the condition. They start worrying about the sleep, or they start spending more time in bed trying to sleep when they can't. And then that kind of reinforces this circular pattern. So the treatment for insomnia, if you do have insomnia, you really want to try to find a sleep psychologist who does what we call cognitive behavioral therapy for insomnia, or CBTI. Because medications are a short-term solution. It's not sustainable long-term, especially in MSA. Almost all sleep medications are going to have daytime side effects or increased risk of falls. So cognitive behavioral therapy is a standardized, researched and validated technique and protocol that involves different cognitive techniques to help relaxation, to kind of focus on sleep environment, biofeedback. And typically this is done in 6 to 8 sessions with a sleep therapist, usually 1 session per month. The difficulty sometimes is finding a sleep therapist who does this. This is not a very lucrative profession, and it's quite difficult. So, there may be some challenge in finding someone who does it, but guaranteed in your area, you do have somebody. And I'm just including this website. You can search. This is one of several websites that lists different CBTI providers. If you have a sleep clinic, I would start there and ask the sleep doctor if they have someone who does this in their clinic, or ask your primary care doctor, because they might have private psychologists in the community who also do sleep psychology, CBTI. If you want to start with a reference on your own, here's a good book that I always recommend to our patients, Quiet Your Mind and Get to Sleep. You can find this on Amazon. It's cheap. It's a workbook that was written by some of our therapists years back, and many patients find it helpful. So when discussing insomnia, it's always important to understand what a circadian rhythm is, because this does influence our tendencies towards sleep and wakefulness. And a circadian rhythm is a 24-hour cycle or clock that's actually intrinsic to most to most animals, and it's actually in almost every cell of our body. We have 24-hour cycles that influence optimal performance of different aspects of our physiology. So most patients that are on a daytime schedule are going to have a peak of alertness a few hours after they wake up, and then there's going to be a dip, during the day, and then the early afternoon there's going to be a period of sleepiness, and then there's going to be another peak in alertness closer to dinner, and then sleepiness again, and that will influence the sleepiness that will induce your nocturnal sleep. And the circadian rhythm is really influenced by sunlight. So in degenerative disorders, including MSA, because of where the protein is deposited in the brain, the circadian rhythm can get disrupted. And we always try to emphasize sun exposure close to the wake-up time. So when your brain sees the light, influences when your 24-hour clock starts. So you always really want to wake up around the same time every day. If you vary that, try not to vary it more than an hour. And when you do wake up, try to get a good maybe 20 or 30 minutes of sunlight coming through the windows. Just open the blinds. If you can go outside, that's even better. And if you can walk or do some form of exercise, that's even better still. And these we call these time givers. These are the things that sort of reinforce a 24-hour pattern in our bodies. Sunlight is the most powerful one. So that's why, again, trying to get natural light around the same time every morning. But also exercise. So exercise, if you do that earlier in the day, that's going to reinforce a daytime pattern. If you're exercising close to bedtime, that's going to reinforce a nocturnal pattern. It might make it more difficult for you to fall asleep. Meals are the same thing. So you want to have your dinner, for example, at least 3 hours before you go to bed, because if you're eating right close to your bedtime, then your body's going to associate that with wakefulness, and it's going to be harder to fall asleep. Also, you need some time to digest, and the digestive function can be impaired in MSA, so you want to allow plenty of time for that. So it's really important to think about this. It's not something that is really discussed in most doctors' visits, but if you're having insomnia, think about your sleep pattern. You want to try and reinforce a consistent sleep pattern, get light when you wake up, do the exercise earlier in the day, and try to avoid any of these things closer in the evening that can make it more difficult for you to fall asleep. Light in the evening is a big problem, in the modern world. You really don't want to have a lot of electronics on. I would say, shut all those off at least 30 minutes before bed. Do something relaxing, maybe read a book, listen to a podcast or music, but you really want to avoid that electronic light that can kind of prolong your bedtime. So then another disorder that's very common in MSA is restless leg syndrome. And we use this mnemonic urge to help remember the symptoms. So restless legs syndrome, or RLS, is defined by an unpleasant sensation. That sensation can be many different things, but it has to be unpleasant. It's characterized by an internal urge to move. You feel like you need to move your legs, right? It's worse if you rest, and it's better with movement. And it's worse in the evening. So again, it has a circadian component. So you can have it during the day, but it should be much worse in the evening. And a good question, again, that gets at all the features of restless legs is when you try to relax in the evening or sleep at night, do you ever have an unpleasant, restless feeling in your legs that can be relieved by walking or movement? If the answer is yes, you likely have restless legs syndrome. And this happens or occurs in at least 28% of patients by some studies. So a very common misunderstanding is RLS happens when you sleep, that I kick my legs, therefore I have RLS. So leg movements during sleep is not RLS. This is a different phenomenon. We call it periodic limb movements. It's not necessarily meaningful clinically. It's not necessarily associated with symptoms or sleep disruption. Restless legs is a feeling that keeps you from falling asleep. It doesn't wake you up. It can keep you from getting back to sleep, but it's not something that happens while you're sleeping. It happens when you're awake. So therefore, you don't need a sleep study to diagnose restless legs. It's strictly a clinical diagnosis based on your symptoms. A lot of patients say, I have restless legs, was diagnosed by a sleep study. That's periodic limb movements, not necessarily something you need to worry about. So a lot of medications exacerbate RLS, many medications. So sometimes it's not possible to stop some of these, but it's always good to go through a list. And if you're having these symptoms, to see if you can change some of these medications. All of those things that I mentioned, those time givers that stimulate wakefulness and circadian rhythm, can also make restless legs worse. So exercise in the evening, meals close to bedtime, alcohol, caffeine, and nicotine. So if someone has RLS, we always want to check ferritin levels. So it's a very simple test, blood test. It's a measure of iron storage. And if the ferritin is less than 60, we treat first with iron sulfate with vitamin C. So you want to take vitamin C with the iron because it helps increase the absorption of the iron, and then recheck the ferritin 3 months later. In some patients who are really iron deficient, we could sometimes use IV iron, which can be quite useful, but it's sometimes difficult to arrange and to get insurance coverage, etc. So then if we decide to treat with medications, there are many different ones. The most common, and I think the safest, would be gabapentin with the least side effects. And then after that, we consider what are called dopamine agonists, which are also used for Parkinsonian symptoms. And these would be pramipexole and rotigotine. There's also rotigotine patch, which is quite effective. Then there are some as-needed medications. Many of these are opiate or opiate-like. Again, these are not ideal in MSA. Benzodiazepines, like we discussed, are not ideal in MSA. But some patients will still use them because the symptoms are so severe, but that's really a last resort. If you are taking a dopamine agonist, like pramipexole, ropinirole, you should be aware of something that's called augmentation. So as you go up on the dose of these medications, as you're increasing dopamine levels, you can start to cause restless symptoms earlier and earlier in the evening, and sometimes they can occur in the day, during the day. And it's fairly common. I mean, 10% almost per year, patients taking these medications will develop augmentation. So if this happens, what we want to do is we want to think about a different medication. You want to get off of that medication or lower the dose and think about using something else. So what will often happen, patients will see a primary care doctor first. Primary care will prescribe these sort of medications, which are the sort of old school classic meds for RLS. And as the symptoms get worse, the doctors will just increase the dose until it starts causing augmentation and making the restless legs worse. And then maybe they'll be referred to a sleep clinic at that point. And then we'll really try to get patients off of those medications. So if you are taking one of these drugs, just be aware you want to keep that dose as low as possible. And then the final primary sleep disorder that we'll discuss is sleep disordered breathing. So I say sleep disordered breathing and not just obstructive sleep apnea, because patients with MSA can have both obstructive and central sleep apnea, which we'll talk about. Obstructive sleep apnea is like it sounds. It's due to an obstruction, typically from the tongue or the muscles in the back of the throat relaxing when you fall asleep. And MSA itself probably increases the risk of this due to the protein deposition in parts of the brain that control breathing. Central sleep apnea, there is no physical obstruction. It's just the brain does not send the signal in time to breathe. So there's not a drive to breathe. And then again, this is from the protein deposition in the brain and the brainstem. And a third breathing disorder that's fairly common in MSA, is fairly unique to MSA, is called stridor. And stridor, if you hear it, it's not something that you'll you can ignore. So it's a very high-pitched, harsh breathing sound, and it's due to inability of the vocal cords to relax during sleep. And I'll play an example sound here. So if you hear that, it's hard to forget, and most partners will report this. And it's important to report this because it's probably associated with a worse prognosis, and it is treatable. So if there are symptoms associated with these forms of sleep disorder breathing, they can include, of course, nonspecific symptoms like sleepiness, more specific symptoms like snoring or the sound of stridor. It can cause frequent awakenings throughout the night. Of course, if there is an obstruction or an apnea, there can be a pause in breathing followed by gasping or choking. Some more subtle symptoms could be dry mouth in the morning, which would suggest mouth breathing, sometimes headaches or nausea in the morning, and of course, unrefreshing sleep, which many patients have with MSA in general. And it's important to diagnose sleep disorder breathing because it's very treatable. It's the most treatable sleep disorder, and we typically treat it with some form of a PAP, a positive airway pressure machine. Typically, this is CPAP. Bilevel or BiPAP is used in some patients. It's not necessary for everybody, but if there is severe sleep apnea, we'll tend to use a BiPAP because we can go higher on the pressures than you can with a CPAP and still keep it comfortable. If there's central sleep apnea, a CPAP alone is probably not effective enough. You need something with a backup rate, so something that stimulates the breathing if there is a central pause. So that could be something called either a bilevel ST or an ASV machine. All of these machines look the same, by the way. They all look like your standard CPAP machine. It's just the mechanics of the breathing apparatus is different inside the machine. For stridor, CPAP or bilevel might be enough, but some patients might require tracheostomy if they're having stridor during the day. And every patient that has stridor should see an ENT doctor to look at the vocal cords, just to also make sure that there's no physical mass that's causing the stridor. And we usually have patients follow with ENT for repeat scoping, just to look at the vocal cords at least once a year. And so finally, if you have problems with sleep, when should you talk to your doctor about a sleep study? Well, there are really a couple reasons we do a sleep study. You don't need a sleep study for insomnia. You don't need a sleep study for restless legs, like we talked about, because those are things that keep you from sleeping. A sleep study is important if there's any form of breathing problem, sleep apnea, stridor, or if there are nocturnal episodes that suggest RBD. And those are the reasons we use a sleep study to diagnose these conditions. And then sometimes we'll do a sleep study to evaluate different treatments. So specifically CPAP, BiPAP, or ASV. We'll often bring patients back for a second sleep study to try out different pressures and different modalities, just to determine which is ideal to treat the sleep disorder breathing, because as mentioned, patients with MSA don't always have straightforward obstructive sleep apnea. They can have some combination of obstructive and central. And to treat that effectively, you really need to do an attended sleep study evaluating these different pressures throughout the night. And I thank you for your attention, and I look forward to answering any questions.